I've got the easiest subject to talk about really, because decompression and squint surgery can sometimes be a little bit challenging to get your head around, whereas eyelid surgery, because you can see your eyelids, is a little bit easier, I think. And I apologize if you can hear lots of noise in the background. My cat's just walked in and scratching everything. Okay, so let's just move this forward. Okay, good. So I'm going to talk fairly briefly, actually, about the types of eyelid surgery that might be appropriate for patients like yourselves with thyroid eye disease, what to expect from those different operations, and then just touch on some other things that actually we've kind of alluded to already. And then, of course, I'm happy to take any questions at the end. So, you're all, I'm sure, very aware of the effect that thyroid eye disease can have on the eyelids. Jill's already touched on a lot of that, and that relates to inflammation and swelling of the eyelids, this kind of bulgy eye appearance. And sort of subsequently to that, the wrong position or height of the eyelids compared to normal, and you can end up with excess skin or fat around the eyes, very red, angry eyes, and dry eyes. So eyelid surgery can correct some of the issues related to that. So the most common eyelid procedures that thyroid eye disease patients end up having done is something called a blepharoplasty and also eyelid repositioning. So we'll take you through each of those kinds of surgery separately now and what to expect. So blepharoplasty surgery is most commonly done on the upper eyelid, though it is possible to have the lower eyelid done. The reason the upper eyelid is done much more commonly is often related to those kind of funding issues that we've talked about, and upper eyelid is more likely to have a functional impact on your vision or the comfort of your eyelids, and that makes it a lot easier to get funding on the NHS. But there are some surgeons that do lower eyelid blepharoplasty, usually privately. And what that involves is removing excess skin and sometimes muscle to debulk the eyelids that have become sort of saggy from stretching and from that process of inflammation that they had before. So as you can see on this particular patient, this nice red circle is just highlighting, as you can see, that he's got these kind of folds of skin that's weighing down the upper eyelid. It's pushing on his eyelashes here as well. And although there's a little bit on the other side, it's much less marked. So how do we do a blepharoplasty operation? Well, we use the natural skin crease that most of us have in our upper eyelid here, to create a wound that we can then remove the excess skin out. And as I say, for some people, we will take muscle to debulk as well. And then we stitch things back up so that you end up with a natural skin crease wound here. With the lower eyelid, you don't have quite the same sort of skin crease there in everybody. It looks a little bit different, but we tend to make a wound sort of underneath the eyelashes, so it still hides fairly well from that perspective in the natural lines around the eye. So from your perspective, if you are undergoing this surgery, what should you expect? Well, this is surgery where, depending on how your hospital runs, you may only be in the hospital for a couple of hours, or you might be in for a morning or an afternoon, but you would not expect to stay in overnight. So it's what we call a day case procedure. So you'll arrive to the hospital, the nurses will check you in, they give you a wristband, make sure that you're well, so that it's appropriate for us to go ahead with surgery. And at the moment, of course, that does include COVID screening questions. You may well have been asked to have a COVID test a few days prior to the surgery, and some places are asking you to self-isolate either just for a few days or perhaps even longer than that. And some hospitals will ask you to change your clothes or pop a gown on. Others don't bother with that, so that's a little bit variable. once all of that has happened, you'll find that the doctors, the surgeons will come around and see you, and that might be one of the consultants. It might be a member of their team, like myself, one of the fellows who will be present for the surgery. And we can answer any questions, any concerns that you have about the procedure you're expecting. Make sure you know what you're having done and what to expect. Confirm that you're happy to go ahead and you haven't changed your mind, because that is entirely allowed, of course. And then if we've done all of that, we may get you to sign a consent form if you haven't done that already, and we'll pop a mark usually on your forehead just to indicate which eye or eyes we're operating on. So what happens next? Well, when it's your turn, you're taken into theatre. You usually walk down there, and you may go directly into theatre, or sometimes you'll go into an anaesthetic room before you go to theatre. And we check you again. You'll get sick of us asking your name and your date of birth, but it's obviously really important with any surgery that we make sure we've got the right person and we're doing the right thing. And we start by giving you local anaesthetic drops to both eyes usually. And the reason for that is, first of all, it makes the eyes more comfortable, so that when we then use our cleaning antiseptic solutions, which is usually iodine, it means that the cleaning stuff itself doesn't sting for you. And then we'll give you an anaesthetic injection, which is much the same as any dental work you may have had. You feel the kind of pressure sensation, you might feel stinging for up to about a minute or so, and then things should go nice and numb. Everybody then gets washed up, we check you again, and then we use that antiseptic stuff to clean usually the whole of your face, even if we're just operating on one eyelid. And then we'll pop a drape sort of around your head and over your chest, which you may find we end up using your chest as a bit of a table for equipment. And you may have a blanket or a warmer on or something like that, because sometimes theatres get chilly. Okay, so having had your local anaesthetic, what does that mean? Well, local anaesthetic works to numb pain and sharp sensations only, okay? So it's entirely normal for you to be able to feel us touching your face or your eyelids, to feel cold or wet with some of the liquids that we use, or tickling sensation if we're stitching around your eye, because you might just feel the actual thread on your face, okay? But you should not feel any pain. And if you do feel pain, please speak up and tell your surgeons, and they can give you some more anaesthetic to get rid of that, okay? You will often see bright lights, although with a blepharoplasty, generally you can just relax with your eyes closed, but we're using bright lights to be able to see, so you might still be aware of that even if you've got your eyes closed. You will hear the surgeons talking either to each other or to their nursing staff who are supporting them, and you may hear beeping in the background from the machines we use to measure your pulse and your oxygen levels, just to make sure that you're okay. Some theatres will have music on, and you can ask for that to be turned up or down if that's bothering you. And you might hear sort of buzzing noises and things like that from various instruments that we use just to stop any bleeding or control bleeding. And for a blepharoplasty, depending on if you've got one surgeon operating or if you have two, so for example, if you have a consultant and a fellow like myself, we may operate on one eye each at the same time to make things a bit quicker for you. And don't worry, we'll always have checked our markings at the beginning to make sure everything's going to end up nice and symmetrical. So, you know, that this procedure can take anywhere between sort of 20 minutes if there's two of you, up to about 40 minutes if there's just one person doing one eye at a time. After the operation, quite commonly people will pop quite a tight dressing over the eye, what we call a pressure pad. And if you've had both eyes operated on, we'll usually ask which eye's got the better vision. And we'll pad both eyes for a short time perhaps a half an hour whilst you're still in the hospital, and then we'll remove the pad from one eye, assuming that your vision's good enough for you to manage until the next day. And then ideally you can take the second pad off the next day. And the intention behind that is to try and minimize any bruising or swelling that you get. You know, you're maybe aware if anyone gets a minor knock to your eye, you can get quite a black eye very easily, and that is a good thing from the point of view of wound healing, because you've got a good blood supply there, but it does also mean that you can end up quite bruised and swollen over after this kind of eyelid surgery. So the pads help with that to some extent. Some people also suggest using ice, so having a cold compress against your eyelids for a maximum of 20 minutes at a time and no more than 20 minutes in an hour, which can help soothe any discomfort, but also reduce swelling and bruising as well. A lot of places, probably the majority of hospitals, will give you an antibiotic ointment to use after your surgery. It's open to debate as to whether or not that's necessary, so not all hospitals do that. But if you are given antibiotic ointment, it's important that you apply it to the stitches themselves rather than into the eye, okay? And that's obviously intending to reduce the chance of you getting an infection, but also it can help keep the stitches themselves moist, which, if they are dissolvable stitches, will help them to dissolve a little bit more quickly. The bruising and swelling may get worse for a few days before it starts to get better, and you generally find that it will settle down over 1 to 2 weeks, something like that. Unless you're on blood thinners, in which case it might take a bit longer because you may have a bit more to start with. And stitches are very, very variable. Each surgeon uses something slightly different, but I would think if you're having surgery in the current COVID period, in order to minimize the amount of hospital appointments that you need, visits that you need, even people who would generally have used stitches they would have taken out are probably currently using stitches that will be absorbed by themselves so that you don't need to come and have them removed again. So here I've just got some pictures from a website called oculoplastic.info, which is by a consultant surgeon in Cheltenham called Richard Caesar. If you don't mind a little bit of gore, he has videos as well as photos of a lot of eyelid surgery if you're interested. But these are just some fairly basic photos that just showing him marking where he's going to go. So you can just see that he's marked the skin crease here. And we often follow a beautiful sort of Amy Winehouse kind of eyeliner flick out at the side, which helps to sort of hide any scars again in your natural wrinkle lines at the sides there. And then what he does is he brushes down the excess skin to work out how much to take away, and we know the limits of what we're able to do. And so in his pre-COVID practice, this is the same patient at the end of their operation. Everything's a little bit swollen because he's had local anesthetic and we've been messing around with the eye, but you can hopefully see that there is less of the excess skin than was over here. And this particular patient has got a stitch in that has to be taken out. So there's stitches all along here, and then it just comes round here. So it would just have to be snipped and pulled. Okay, so so that's blepharoplasty surgery. So now I'm going to talk about eyelid repositioning. So for most people with thyroid eye disease, their eyelid will end up too high, like you can see with this lady. So generally our upper eyelid should sit somewhere near the top of the iris, the coloured bit of the eye, and hers is sitting a couple of millimeters too high, and that can lead to dry eyes and dry, red, irritable eyes, even when the rest of the thyroid eye disease has settled down. So she here has had her upper eyelid lowered. I suspect she may well have had a little bit of a small blepharoplasty done at the same time, but that doesn't have to be the case all the time. And her other eye has also been lowered a bit too, but it looks less obvious to start with, doesn't it? You can also end up with a lid too low, so we then pull it up, and the same goes for both upper and lower eyelids for this particular problem. So overall, this is a very similar experience from your perspective to having blepharoplasty done. But the key thing really that's different is actually we need your involvement a lot more, and it can take longer depending on how many adjustments we need to do. So we use our sort of general experience to try and get the eyelids in a better position. And again, that the technique we use will vary depending on whether we're trying to lift it up or lower it down. And then once we think we're in the right place, what we'll do is we'll move the lights away and we get you to open your eyes, okay, and get you to look at a target and move up and down, and we're just checking to see how that eyelid moves and where we think it's going to naturally sit, and if need be, we may have to just keep tweaking and tweaking until we get that into the best possible position for you at the end of the operation. Now, with a lot of these surgeries, we get things in the what we think is going to be the perfect position at the end of the operation, but then your own body comes into play and everybody heals slightly differently. So for some people, when they heal, things scar up, and for some people things sort of relax off again. So very occasionally people need sort of more than one operation if things don't work quite as we'd expected. So just the same as with blepharoplasty, you may have a pad over that eye, you may want to use ice, you may have some antibiotic ointment, and sometimes for this kind of surgery that would need to go in the eye as well. It really depends on what's done, so you'd need to check with your surgeon about that. And you're more likely to be followed up sooner with this kind of surgery because we want to check that we've got the height correct, particularly if we're raising a lid that is too low, because we don't want to create a problem where the eye can't fully close and you end up with a very dry or very sore eye as a result of that. And very occasionally we use some exercises if the lid is sitting too high and we'd intended to lift it up, but it's too high. We sometimes will get you to try closing your eye. You hold on to your eyelashes very close to where your eyelid is, and you look up to stretch the muscle. And just the same as Jill was saying earlier, because you're trying to stretch a muscle, it should be uncomfortable, it should be a bit sore. If it's not, you're probably not doing it quite hard enough. But that's, as I say, only used for a very small number of people, so you need to be guided by your surgeon on that. And overall, you may find that you have a change in your drops, particularly if you're using lubricating drops. And we hope, of course, that by doing this, that eventually that will be fewer. But immediately after any operation, the eyes can be sore and irritated. So don't be surprised if you need to use more just for a short period of time. So other treatment options, you never have to have surgery unless there's something sight threatening, and even then there's debate on that. So there are other options that you can try. So we use lubricating drops and lubricating ointments all the time, as I'm sure you know, and they're a little bit like shampoo, whereby there's dozens, if not hundreds, on the market, and it's all about finding something that works for you. And some people find that things become a little bit less effective over time and they need to switch it up and then come back to things. So don't worry if you find that's the case for you. The key thing really is if you're needing moisturizing, lubricating eye drops in a longer term, we would always encourage you to avoid preservatives, because the preservatives can actually aggravate the problem if you're needing them a lot. One other thing that is sometimes used, and sometimes we try it and it doesn't work and we still end up doing surgery, but it's often worth a go, is if the eyelid's sitting a bit too high and everything's very actively inflamed, then sometimes we can give you an injection of steroid into the eyelid to try and dampen down that inflammation and hopefully drop the eyelid down a bit. So when do we want to do this surgery? Well, I think we've hammered it in fairly hard today that actually doing the orbital part of any decompression surgery first, and then your squint surgery needs to come before your lid surgery. And of course, this may be that people have quite a long course of treatment before they get to the stage of having lid surgery. If you can imagine, if you've had medical treatment like steroids for a few months, and then you've needed decompression, then you've had to wait for things to stabilize before you have your squint surgery, etc. So this might be a surprisingly long time down the line. And really, we want things to be nice and stable, and ideally, we don't want you to be having active disease that might change the situation, again, unless there's an emergency. And we've just touched on CCG policies, so clinical commissioning group policies, and this is only for England. It is different in Wales and Scotland. And so Rebecca and I did a piece of work looking at various eyelid surgery funding. So a third of CCG policies a couple of years ago mentioned thyroid eye disease in some form or other. And then 10 CCGs had specific thyroid eye disease policies, so separate to their blepharoplasty policies or their ptosis policies, for example. And they all stipulated that in order to qualify to get funding for eyelid surgery, you had to have been using lubricating eye drops for a minimum of 6 months, and as they put it, failed that. So essentially, finding that that is inadequate. Now, I'm not quite sure how strict they are on that, so it might be possible to argue, for example, if you were needing drops every half an hour or an hour, well, that's not sustainable long term, and it's exceedingly disruptive to your life. So then there may be some wiggle room with that. I don't know exactly what they mean with their terminology of failed, but that's the policy for those 10 CCGs. Okay, so that's all I had to give as part of a formal presentation, but I'm very happy to take questions, and I'm going to stop sharing my screen.